Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. I'm Sapna Patel.
My name is James Larkin.
Welcome to our episode today. We're going to try something different and start out with a quick fire. So, James, let me ask you just some rapid fire questions. Or do you prefer coffee or tea?
Yeah, it depends on the time of day. I think coffee in the mornings, tea in the afternoon. Standard British answer, maybe.
Same. I'm actually an either or person. What was your last workout?
Oh, yeah, I'm injured at the moment. So I'm stuck doing squatting and conditioning. So this morning I just did 40 minutes of conditioning, which was fairly unpleasant and boring, but needs must.
And what about, do you prefer the American version of The Office or the British version of The Office?
I've got no idea because I've never watched the American version of The Office, and I found the British version of The Office quite difficult. The cringe factor for me, just I could barely watch. I could barely watch it actually, really. But there we are.
I actually saw it last night on TV, so I ended up watching the end of season 1 and beginning of season 2. It's outstandingly cringy. They perfected it.
Yeah, is that really entertainment? But maybe that's another question.
Well, today let's talk about one of our landmark adjuvant trials, the EORTC 18071 study, adjuvant Ipilimumab versus placebo after complete resection of stage 3 melanoma. This was a randomized double-blind phase 3 study. And as you know, this is our only study that actually has overall survival benefit in the adjuvant setting using checkpoint inhibitor. Let me just summarize it for listeners and then we can jump into it. So this was a study of almost 1,000 patients, 951 patients with cutaneous melanoma. They needed to have lymph node involvement. And here they use that Rotterdam criteria where it needed to be 1 millimeter or greater lymph node involvement. They needed to have complete resection of the primary melanoma and lymph nodes. And then they were randomized 1-to-1 of high dose ipilimumab, which was 10 milligrams per kilogram every 3 weeks for 4 doses, followed by a maintenance, which was the every 3 month schedule for up to a total of 3 years. Or placebo. So these patients did get a placebo infusion every 3 weeks for 4 doses, and then every 3 months for 3 years. And the primary endpoints were recurrence-free survival and overall survival. And then, of course, they also looked at distant metastasis-free survival, which some think, is maybe a surrogate for overall survival because it's involving the occurrence of distant metastasis. So there we are. That's the summary of the study. What do you make of this?
Well, at the time, obviously a really, really important study. You can't argue with that OS benefit. I think that's one thing to say. Maybe we can talk about IPI dose a little bit and side effects in a minute, but maybe I'll flip it back to you and ask what you thought of the control arm in that trial. I mean, which is really a question about the role of adjuvant interferon historically, quite polarized around the world, popular in the US, but not universally so. Is that a fair statement or not?
The adjuvant interferon?
Yeah.
Yeah, I mean, the ECOG group obviously established a lot of the use of adjuvant interferon in the 90s in the US. EORTC was also really involved, investigating different dosing schedules. But it was also controversial in the US. It was a therapy that had RFS and OS benefit to start, but over time, the overall survival benefit waned. And so the use of adjuvant interferon really dwindled when that OS benefit was lost. Often we would hear the surgeons surgically cure these patients and then send them to medical oncology and say, you don't really need that treatment. It's fairly toxic and there's no survival benefit. Some of the counseling we were giving our patients back in the day when we were still using this, though, was there is clearly a benefit in recurrence-free survival. So it's, maybe this is an American term, kicking the can down the road of when your melanoma might recur. If that's the case, the thing I used to tell patients is it may be beneficial to kick that can down the road because no telling where our medicine will be in a few years. And if you recur at 7 years instead of 4 or 5 years, we may have access to new therapies. And it's, I don't claim to have a crystal ball, but boy, that's exactly really what happened. It's several patients I treated successfully with a year of adjuvant interferon or more, depending on the regimen, pegylated or non-pegylated interferon. And then they did really well for a number of years until their melanoma came back. One actually comes to mind because it's actually a dear friend, patient of mine who did adjuvant interferon back from 2011 to 2000, maybe 13 or 14. So this was pegylated interferon. And, only in 2023 did the melanoma recur. So, got nearly a decade's worth of benefit. You would have to believe that's benefit from some immune surveillance heightened by that interferon, but that lack of overall survival, I think, was really controversial. But let me ask you this: what could they have used if not placebo? Because interferon's not the same, dosing. It's subcutaneous dosing. It's not necessarily intravenous, except maybe if you use traditional interferon for that first month. The dosing schedules don't line up. So you would have exactly known what somebody was getting, which we know will psychologically bias the results.
Well, yeah, you maybe need to do open label, but I mean, there are examples of that, I guess, happening. That's one thing. Or you could have a very complicated placebo randomization where, both arms are getting massive numbers of interventions. Some are placebo, some are the therapy. But I think the latter is probably just actually not feasible, to be quite honest with you. The complexity, you'd have loads of patients falling off. So then what about tolerability? I know there's quality of life data, all that sort of stuff, but, as someone who's treated patients with it, how much impact on average, maybe, would you say it had on people's day-to-day life when they're having adjuvant interferon?
That was a daily struggle. I mean, I would tell patients, you will know you're on treatment and you will walk around feeling like you have the flu because, as avid medical students would know, the cytokine that you secrete during a viral illness is interferon alpha. And so we were giving patients high doses of this interferon alpha, essentially making them feel the entire year febrile. They were having myalgias. You could have subclinical changes in your blood counts and your liver enzymes and things like that. And one of the black box warnings for interferon was suicidal ideation. And I had my senior partners at the time had all lost a patient to suicide. And it was no small thing. And I had a patient, very, very memorable. I had 2 that really struggled with this, that I had to abort the treatment for. One had significant postpartum depression, was years out from that, and was a nurse herself. And so she had insisted on, she needed to take adjuvant therapy. She needed to do everything possible to lower her risk. And then very quickly, became psychotic. And her husband called me and said she was digging the needles out of the trash can and feeling like she didn't inject it all. At one point, she wanted to inject it into her eyeballs because she thought it would be directly, infused. So, we immediately got her hospitalized, even though she was in a different city. And we just recognized this was not in her best interest. And another patient who was a marathon runner, and he, marathon runners are very diligent, if not disciplined in the way they train. So usually running 4 to 5 days a week with a long run on the weekend. And his wife called and said he's not getting up out of bed. I'm concerned he's not even going to work. And you worry about these really high functioning people because their, ability to commit suicide, unfortunately, can be much linear and faster. So similarly, I said, if your quality of life is running and we're not doing that anymore, don't we think this is taking a bigger toll than it might be worth? And so after those 2 patients, I didn't start anybody on adjuvant interferon without a psychologist involved, without a psychiatrist, because even if they were quite stable walking in the door of adjuvant interferon, that therapy has a way to unglue our brain chemistry. And I felt like everybody could benefit from just, having another specialist on board. So that is a very difficult one to sort of quantify on a day-to-day, but the flu, the fact that they could physically feel manifestations of this treatment was difficult. But it's not that Ipilimumab, particularly high-dose Ipilimumab, is devoid of side effects. I mean, we certainly see that in these high-dose trials, right?
No, and I mean, I guess that's the obvious segue, isn't it, into IPI-10, what the side effects look like. And maybe for me there, the headline is the treatment-related mortality, which I think from memory, at least in this trial, was around about 1%, the risk of dying, which is not trivial, to say the least.
In the adjuvant setting when you're cured of your melanoma, yeah.
Yeah. Never mind the IPI-10 side effects, which are, of course, like the IPI-3 side effects, but worse. And so, possibility of fierce colitis and so on and so forth. So that is obviously not a treatment without toxicity, to mix negatives in the same sentence. So next question then. So why was there a survival benefit in that trial, and then none of the subsequent trials that have been done over a few years now have we really seen a survival benefit?
I mean, it's a good question. Maybe I should have done some more homework on this. My instinct is to say all the other checkpoint inhibitor adjuvant trials are PD-1 therapy. And so it's those trials end up really being a question of PD-1 now or later. So can you salvage somebody with PD-1 later in the course of their melanoma treatment? Whereas Ipilimumab, many people, if they get it later, they get it in combination. So there may be something to getting CTLA-4 blockade early in the immune sequence that does something beneficial. And then later, when if those patients need to get salvaged with PD-1, they still have an edge over somebody who took placebo in the adjuvant setting. I don't know. That's my take. What do you make of it?
Yeah, I don't know. But I mean, the most sort of plausible explanation to me is the possibility of salvaging people later on, certainly in the modern era. And at the time that trial was done, if you looked at what would happen to people who develop metastatic disease, I doubt there would have been much access. I guess we could check to treatments in the metastatic setting with OS benefits. So that I think that speaks to that point. But maybe we can come on to that a little bit later on, and as well as think about a little bit about the dose of it, because I think that's an interesting thing. I was going to say one other thing actually, which is my whole kind of experience of using IPI, and this isn't really theoretical or data or anything like that, is that this is a drug that absolutely works best in people who are well. They've got intact immune systems. They're not immunosuppressed, either exogenously with immunosuppressive drugs or as a consequence of tumor burden. And maybe just a footnote here that IPI monotherapy, 3 milligrams per kilogram for metastatic disease, really just does not work in people who've got high LDH or poor PS or a big tumor burden. So to me, that's very plausible. And I'd probably make a similar type of observation as well, actually, in kidney cancer, but I don't want to digress too much on that.
So actually, as you make that point about subsequent therapy, it's in the European Journal of Cancer publication, this 2019 publication. It's their table 1. What did patients get after disease recurrence? So I actually think your explanation is far more plausible than mine. Who got second line therapy? Well, 80 to 87% of these patients got second line therapy, but who got our modern therapies, BRAF MEK inhibitor and anti-PD-1 therapy? Very few. Only about a quarter of patients got BRAF inhibitor, and 11 to 12.7% got anti-PD-1 as salvage. So perhaps if you're not getting salvaged by PD-1, that's why you have this survival benefit. And perhaps if that study was done in the modern era where people could be salvaged with PD-1, maybe we wouldn't have an OS benefit with adjuvant.
Yeah, I agree with that, but I guess we'll come on to discuss that a little bit when we talk a bit more about the now or later.
Yeah. So adjuvant IPI versus placebo, EORTC 18071. It's an important study to know, though probably in practice, few people are using this therapy. And it has a significant benefit in RFS, DMFS, and OS with a long follow-up of about 7 years and hazard ratios of about 0.75 for RFS, 0.73 for OS. So I guess that's a wrap on EORTC 18071. Thanks, James.
Thank you.
Hi, everybody. I wanted to do a citation and quick fact check for EORTC 18071, adjuvant Ipilimumab versus placebo. Wasn't sure if we mentioned anywhere in the recording the actual publications. So the first publication was in the Lancet Oncology, Lex Egermont et al., and this reported the RFS. This was 2015. A year later, 2016, Lex Egermont et al. In the New England Journal of Medicine reported out the overall survival benefit. And then a year later, 2017, in the Lancet Oncology, it was Cornel Coens, Coens, as the first author, and Lex Egermont as the senior author, reporting the health-related quality of life. The top line result there is that despite higher toxicity in the Ipilimumab group, and obviously that means a higher drug discontinuation rate during that induction phase, the quality of life was no different in the two arms, and this was assessed by using the EORTC QLQ 30 Global Health Questionnaire, and a difference was defined as more than 10 points in that quality of life questionnaire in the two groups. And at least during the induction period with higher dropout, higher toxicity, and Ipilimumab, there was not more than a 10-point difference in quality of life in these two groups. The last thing I wanted to mention was about grade 5 adverse events. James talks about a 1% rate of death in this study, and that was right. Remember, it's the adjuvant setting. So these 5 deaths out of 915 patients accounts for 1% of participants in the Ipilimumab arm. 3 of those deaths were from colitis. 2 had perforation from their colitis. 1 was from myocarditis, and then 1 was Guillain-Barré, leading to multi-organ failure. So that's it for fact check for EORTC 18071.